Hey, Dr. Hammond here. How are you? Um, so this is a presentation for the Los Alamos Police Department dispatchers. Different than some of the other talks you might have seen or viewed, as part of your training or education stuff. This one's really designed to be somewhat short and sweet and not dive into pathophysiology and some of the stuff that doesn't pertain to you guys. So this one is more focused on the dispatchers. And the goal here is just to provide you with a handful of topics over the course of the year, and giving you really kind of the background medical education behind what it is when callers call in and talk to you about, somebody's having a stroke, a heart attack, and seizures. And so we'll pick some of these topics, and then really just give you a little bit of the medical piece of what the caller's seeing, what they're experiencing, what EMS is going to do, and what happens in the hospital, and then a little bit of just the understanding of the disease as well of what we're even dealing with in just the medical field. My goal is to kind of keep these short and sweet. I would say, 15, 20 minutes is what I'm going to shoot for. We'll see how it pans out. My attention span is short, but I tend to be long-winded sometimes. So who knows where it's going to go. This month, we're going to talk about strokes. So the American Heart Association, let me share this a little bit there. The American Heart Association has a campaign out there called FAST, and it's an acronym that stands for FAST, facial droop, arm weakness, slurred speech, and time to call 911. So this is designed really for the common stroke, right? The one that we very obvious that somebody's having a stroke, that they can't speak, they've got droopiness to one side of their face, arm and leg weakness, they can't fall, they're slumped over, something like that. So this is really designed at some of the bigger strokes. Obviously, like everything else, stroke is a complex problem, right? And you can have small strokes that affect a sensory and not a motor cortex. You can have seizures associated with strokes, not just be a seizure, but actually a stroke as well, depending upon what part of the brain is affected. So this is designed really for kind of the basic stuff, the basic big normal stroke that you see on TV or kind of wherever, where you get facial droop, people can't speak, and they've got some weakness in their arm, their leg, or something like that. Sorry, let me bring. There we go. So here, kind of the three types of strokes that I would say we can address today are, there's one called an ischemic stroke, a hemorrhagic stroke, and a TIA, or a transient ischemic attack. So an ischemic stroke is I guess it's the most common one, being that it is the one that we probably think of what a stroke actually is. So it's the same as a heart attack, right? So it's the same pathology. It's a blood vessel that has got blood passing through it and somehow becomes occluded, right? So when that blood vessel is in your heart, it is a heart attack. The same blood vessel with the same occlusion in your brain becomes a stroke, and that's what ischemic is, right? So ischemic means lack of tissue perfusion. So there's not the nutrients in the blood getting to a certain part of whatever organ, and in a stroke, that's the brain. So this is, can be caused by lots of reasons. So commonly, like patients who are in AFib create clots in their heart, and those clots then shoot up to their brain and get clogged, just like any other pipe with something in it. And then it doesn't allow blood flow past that. And so everything past that area where the clog isn't getting oxygen and the nutrients from the blood. And we call that an ischemic stroke. A hemorrhagic stroke is a bleeding stroke, right? It's not that the tissue is just not getting blood, it's that blood is actually leaking out of the tissue into the brain in the stroke scenario, right? So very commonly, those two are tied together, because what happens is you get an ischemic area that the tissue then dies, the blood vessels become frail, and then they start to bleed. So not uncommonly do we initially, patients have an initial ischemic stroke that can progress to a hemorrhagic stroke. And a TIA is, it's a stroke that is self-limited, right? So it's grandma on Thanksgiving Day who comes in with slurred speech, facial droop, arm weakness at the kitchen table, and by the time they get her here, she's back to normal and doesn't know why she's here on Thanksgiving Day. She still had a stroke. It's just a short period of a window. So a TIA is, the other term is mini stroke, and it's basically what it is, right? It's a stroke that is very short-lived. The true definition of stroke, you have to almost watch patients for more than 24 hours. So 24 hours out, whatever symptoms they have, that's kind of the diagnosis of a stroke. And if those symptoms resolve in 24 hours, we categorize it as a TIA if they go completely back to normal. So there's kind of your three main ones. Does this matter to you, talking to a patient on the phone, whether it's ischemic or hemorrhagic TIA? Not at all, right? There's a neurological change in the patient. They can't speak, their face is droopy, they can't lift their left arm. The cause is the treatment's going to vary to some degree, but the initial evaluation is still going to be the same. So here's this kind of difference between ischemic and hemorrhagic. You've got the blood vessel basically occludes here, and then everything just beyond that is not getting perfused. So when we talk about big strokes, so you have big arteries that go to the certain parts of the brain, right? If you've heard of it, it's called the MCA or ACA, the middle cerebral artery or anterior cerebral artery. And it's really these big blood vessels is what we're talking about, that if they occlude kind of close to their base, it affects a large area. And if you take this blood vessel further and it occludes somewhere out here, it's going to affect a much smaller area. Conversely to the hemorrhagic one, you've got blood flow still and things are bleeding, and often, again, those can be combined. So this diagram here is called the homunculus. I've always found this thing to be super fascinating because it depicts in size and location kind of where sensory and motor things in our brain come from. So basically, if you take the brain down here and you cut it cross-sectional, right? So you're going to cut like the head in half. And you did like just a cross-section of the brain. This is what you get. You get one side that's motor, one side that's sensory. And the size of everything drawn on here kind of gives you an idea of how much of the brain is fed by this or kind of taken care of by this area. So as you can see, like if you talk about like your inner arm up here, there's not a lot of neurological involvement and nerve endings, whether motor or sensory, dealing with your armpit area, right? When you get to the face, right, the face is huge in this diagram. The tongue specifically has its own little location because it's such a complex motor with fine motor, fine sensory, all this stuff. So I just found this always to be super interesting, that if you infarct the left side of the brain at a major vessel back here, you're going to kill this whole area, and that's where that sensory or motor or facial droop is going to come from, depending upon which side it's on. And the strokes that we notice are the ones that are in the big blood vessels, kind of further down towards the base, right? If you infarct something kind of towards the tip, towards the end of the brain, you're not going to get a lot of sensory changes that you're going to notice on your inner arm or your armpit. You're going to notice it when it infarcts something big like the face. So that's why it's more common to see speech and motor and facial things, is because it is a big portion of what's innervated, from the different parts of the cortex of the brain. So yeah, this has always been super fascinating to me. And then this can tie into lots of other stuff of like where, if we talk about the anterior cerebral artery and why is this affected and not this. And so you can map things out based kind of on this. So always found this fascinating. So the other problem is medicine is never straightforward, right? Patients don't read the same textbooks that we do. And so there's always complicating factors. So common mimics of strokes, with these are kind of the four big ones: hypoglycemia, seizures, Bell's palsy, and intracranial hemorrhages. So the first one, hypoglycemia, every patient with a neurological deficit is going to get a pre-hospital blood glucose level. And our guys they're always on top of this. I remember I remember one of the times I diagnosed early on in residency was I missed getting a blood sugar because the patient came in by mom carrying this baby in her arms, and I didn't check the blood sugar in the first 5 minutes and thought the baby's having a seizure. And we go down this whole seizure pathway, and then we find out the blood sugar is super low. And I would tell you, our EMS crews, this is not something they ever miss. And so it's really valuable, easy piece of information to rule out a common mimic from a stroke is hypoglycemia. So the next one, seizures, complicated, right? So seizures, you can have, there's so many things that go on with it. So whether patients, had a seizure and are in that postictal state and they're just not moving from that. There's a thing called Todd's paralysis where you truly have paralysis after having a seizure and it is nothing related to a stroke. You can have a stroke that causes a seizure depending upon what area of the brain it causes. So this is a kind of a mimic, but a hard one too, to kind of differentiate out if it's part of the kind of medical decision making. Bell's palsy is another great one, right? There are lots of people who come in who think they're having a seizure and it's a Bell's palsy, and we'll look at that. And that's just we talk about motor cord, the motor part of the brain, the beyond the brain part of where the motor comes from. There's also just the basic nerves, right? And so this is a problem with the nerve of the face, not the brain part that innervates the face. We call it a peripheral nerve palsy, and the most common one is called a Bell's palsy. I'll show you kind of how to. There's some differentiations in that. And then intracranial hemorrhages. So this is actually this is the whole reason we get a CAT scan, is because one of the mimics of stroke is just a bleed in the brain, right? A blood vessel that ruptures, an aneurysm that ruptures, it's bleeding into the brain. And so when patients, they're picked up by EMS, they're brought to the ER, they're very rapidly taken to get a CAT scan most of the time, right? There's windows and hour limits of things for what we can do, but they're often whisked off to CT pretty quick. A CAT scan will not show a stroke. That's not what it does, despite kind of what a lot of the people and patients think. A CAT scan will show a stroke if it is a large stroke and if it's old. So a CAT scan shows it when the brain tissue has started to die and there's some changes associated with that. That takes, they say 24 hours is what most literature says, for the brain to change enough to see evidence of tissue damage on a CT. So why do I do this so fast? Like, the actual thing we're looking for is the mimic of a stroke, and an intracranial hemorrhage is one of the most common things. And if you see that, it alters the entire pathway of what we're going to do with the patient. So this is why people are rushed off to CT very early on in the stroke process. So here's Bell's palsy. Take a picture, two pictures of, one is a stroke, one is a Bell's palsy. So they talk about them as up here this says a little fuzzy, I'm sorry, it says peripheral facial palsy, and this one is a central facial palsy. So central facial palsy, meaning the brain. So this is what a stroke patient looks like with facial droop. So they're unable to smile on this side, their eye is droopy, and they're able, this is the key difference, is that even in a stroke, they're actually able to raise their eyebrow. So let's say you have droopiness on the left side of your face. Excuse me. Droopiness on the left side of your face. If it's a stroke, you're still able to raise your eyebrows on the left side. You'll raise the right ones like normal, and your left one will raise as well. In a peripheral nerve palsy, because it's not the brain that's affected, it's the nerve itself that's affected, you lose the ability to raise your eyebrow on the affected side. So they'll come in and they'll look similar like a stroke, right? They have droopiness to their face. They can't close their eye all the way. Their eye is dry and they can't blink, and they are unable to raise that eyebrow on that same side. It goes into this whole cross neurological pathway in the brain, but it's a key difference. And granted, there's always, medicine again is complicated, and there's always caveats to that, because there is a certain stroke that has the ability to not raise eyebrows. It's so weird. You have to go. I have to look stuff up all the time about it, but it does exist in a stroke, but not very common is the basis of it. So if patients are able to raise their eyebrow on the affected side while they have speech problems, much more likely to be associated with a stroke. If they're not able to raise it, it's far more likely to be associated with a Bell's palsy. And what is a Bell's palsy? What do we do? Really not much. There's a handful of causes that you can look for to address, but most of the time we call it idiopathic. We don't know why it occurs. Put them on some steroids, and most people will get better. So let's talk about then treatment, right? So the caller has called in and you've dispatched them and the appropriate units. EMS has got there. They obviously check their blood sugar, and then we arrive to the hospital. So first thing I'm going to do if they're in this kind of window is we rush them to CT. And the window I talk about is there's about a 4-ish hour window that from the time you start having symptoms of a stroke, 4 hours later is my opportunity to give you this medication called TPA. TPA is like a clot buster is what some people call it. So it's supposed to help dissolve the clot that is occluding the blood vessel, right? It's like Drano for your clogged pipes in the bathroom, right? Same kind of thing. It's going to help break down whatever is clogging it. There's lots of studies, contraindications, all kinds of stuff, but that's what we're rushing for, is because we have this short time period. So immediately they come in and go to CT. Some people talk about, do you give aspirin to strokes like we give aspirin to heart attacks? And the answer is really no. You have to give it within 24 hours in certain cases, but I'm not rushing to give somebody aspirin. It's not a life-saving medication like in a heart attack. And the possibility of it is if it's a bleeding stroke and you give them aspirin, you've now inhibited their platelets and now they're going to bleed more. And so I'm really not a fan of rushing to give anybody aspirin. That TPA, within the window, there's a lot of contraindications. I mean, there's a whole list that I go through of 13 reasons why they cannot have it and the 5 reasons why they can. And really, they have to meet a lot of criteria to make sure of this. So many patients nowadays are on these fancy blood thinners, and you've heard of Xarelto or Eliquis for patients AFib, and there's commercials about it. And if you're on any of these, you can't really have TPA. It's a contraindication. And so a lot of patients just buy their own medicines really don't meet criteria to get this medication. The coolest part about strokes and our progress on how to manage them doesn't apply to us, and it's not anything we're doing here. It's not even what they do in Santa Fe, and really the only place in the state that's doing anything of a major intervention in terms of stroke is at UNM, where they can do all kinds of intra-arterial things, right? They can go in, feed this line into the blood vessel that's occluded and squirt TPA directly at the clot and try to dissolve it. They can do this clot retrieval thing where they kind of fix a coil around it and grab the clot and pull it out. There's lots of things that they're doing with MRI stuff. I mean, it's really cool stuff, but it all has to be done at UNM. And so a lot of our patients here will do not only just the regular CAT scan, we'll do a CAT scan with IV contrast to look for the actual occlusion, right? So I feed dye into their arteries and light it up and see which one's blocked. And sometimes it's perfectly aligned and we can get them to UNM and they can do really good interventions, but not as advanced as we would hope, like heart attack stuff is where every hospital it has a cath lab and a cardiologist. Really, it's kind of localized to UNM. So if you see patients getting transferred there, it's because we found something that we can really treat, and that's the best place for them. Prognosis for strokes, it's so variable, right? I mean, we have patients who've had massive strokes, and you look at them, and you're like, man, this is so sad, and they're never gonna be the same. And 3 days later, I go upstairs and check on them, and they're feeding themselves cereal and talking and changing the TV channel. Like, it's so crazy how some patients do really well and how poorly other ones do. Most of it's based on really just, did that tissue in the brain get perfusion? And if it does restore perfusion, they do really well. And if it doesn't, they have a much harder time. And so that's where really long-term physical therapy, speech therapy, things like that come into play, is to try to retrain the brain to some degree that they can be, perform their activities of daily living is what we're after. So, that's the basis of it. So quick little video on strokes, and we'll do another one hopefully within this next quarter. And if you have questions, always forward them to Kate. You can send me an email. I can either answer them in the next video or kind of get back to you on email as well. So thank you guys very much for paying attention, and appreciate your time.